Welcome back to the deep dive. Our mission today is, it's highly specialized and it's intensely critical.
It really is.
We are plunging into the world of acute coronary syndromes, and specifically, we're looking at this really complex landscape known as non-ST segment elevation acute coronary syndrome, or NSTE-ACS.
Right.
And this is a condition that demands not just, a rapid diagnosis, but precise, nuanced, multi-layered decision-making, often in the space of just a few minutes.
This is truly a high-stakes area of medicine. I mean, when a patient presents with symptoms that even suggest a heart attack, that immediate triage is probably the most important decision they're going to face that day.
It's a huge fork in the road.
It is. It's the difference between, say, a total, undeniable plumbing blockage that requires an emergency crew right now versus a partial failure that requires an expert to analyze the structural integrity, the pressure, and the internal environment before deciding the exact timing of intervention.
And that triage, it all starts the moment the patient arrives and gets hooked up to the very first test.
Yeah.
The electrocardiogram, the ECG.
The ECG, right.
And this single piece of paper, it immediately sorts patients into two big stacks for management. If the ECG shows that critical ST segment elevation, that classic, really high-risk pattern, the patient gets immediately categorized as a STEMI.
ST segment elevation myocardial infarction.
Exactly. And we know that means the coronary artery is completely shut down, time is muscle, and they are on the clock for immediate revascularization.
That's the easy answer, terrifying one. The STEMI patient, they basically bypass most of the deep dive we're about to take.
Right.
But the rest of the patients, and this is the majority actually in the modern era, they fall into this NSTE-ACS category. The N for non tells you they lack that massive ST elevation, but it absolutely does not mean the risk is low.
So NSTE-ACS is our focus today. And what makes this category so difficult, so challenging, is that it's still split into two distinct clinical diagnoses, even though they present almost identically at first. We have non-ST segment elevation myocardial infarction, or NSTEMI, and then we have unstable angina, UA. How do clinicians tell those two apart?
It all comes down to the blood test, specifically cardiac biomarkers.
Okay.
So both patients have symptoms of acute myocardial ischemia, that's, oxygen starvation in the heart muscle. But in NSTEMI, myocyte necrosis, or heart cell death, has actually occurred.
And you can see that in the blood work.
You see it as elevated cardiac troponin levels. In unstable angina, the symptoms of ischemia are there, but the biomarkers stay normal, which means there's no detectable cell death, at least not yet.
So unstable angina is kind of the ultimate warning shot. You have severe symptoms, but no confirmed damage yet. And NSTEMI is the confirmation that damage has started.
That's a great way to put it.
And it seems like this classification is really shifting based on just how good our tests are getting.
That's a key observation. It's a huge point. When you look at the incidence trends, you see STEMI rates are actually declining.
Which is great news.
It's a huge success story for preventative medicine. Fewer people smoking, better use of statins and aspirin. We're getting better at preventing those totally occlusive clots.
But at the same time, we're seeing NSTEMI incidence rising. Why that simultaneous increase in the non-elevated group?
There are two main drivers for that. First, just the aging population. People are living longer, and they're living with more comorbidities, obesity, type 2 diabetes, chronic kidney disease.
So more complex patients.
Exactly. These patients inherently have more complicated and diffuse atherosclerotic disease, which makes them more susceptible to partial blockages rather than total ones.
And the second driver, which you kind of alluded to, is the technology itself.
Precisely. The widespread adoption of highly sensitive troponin HSTN assays has just fundamentally changed the game. I mean, these tests can detect minute amounts of heart cell leakage that traditional assays simply missed.
So we're seeing things we couldn't see before.
We are. A patient who maybe 20 years ago was diagnosed with unstable angina because we couldn't detect any necrosis is now quickly reclassified as an NSTEMI because we can see that tiny yet significant spike in troponin.
So we aren't necessarily seeing more disease, we're seeing the existing damage sooner and much more clearly.
That's it, exactly.
That's fascinating. Technology actually changing the classification of a disease. At its most fundamental level, acute coronary syndrome is always a supply and demand problem. The heart needs oxygen, that's the supply, and it's not getting enough of it, often because of a blockage, while its workload, the demand, might be way too high. But the complexity, and this is where the sources really shine, is in the details of how that blockage forms, because it's not just one standard process.
No, it's not. The primary mechanism, which is responsible for the vast majority of cases, is coronary arterial thrombosis that results from atherosclerotic plaque disruption. And the sources distinguish between three underlying thrombotic mechanisms, which basically describe three different ways the internal structure of the blood vessel can fail.
Okay, so let's start with the one we all picture first. The classic idea of an unstable plaque just rupturing. What defines that?
That is the classic plaque rupture, or fissure, and it typically comes with significant inflammation. The plaque we're talking about here is characterized by being highly unstable. It has a very thin fibrous cap covering the inner lumen.
So a weak covering.
A very weak covering. A cap that is poor in stabilizing collagen, and underneath it is this massive, soft, large lipid core. When that thin cap breaks or ruptures, the contents of that big lipid core spill directly into the bloodstream, and that immediately triggers a massive clotting cascade.
And that cascade results in a very specific kind of clot.
It does. The thrombus that forms is typically described as a red, fibrin-rich thrombus. It's highly influenced by the blood's clotting system just reacting violently to the plaque contents. And what's more, this rupture is often fueled by inflammation. It reflects increased activity of effector T cells and a kind of dysregulation of the adaptive immune system that's attacking the artery wall itself.
So that's the fatty balloon popping, basically. But what about the other failure mode, the one that's being recognized more and more? Plaque erosion.
Plaque erosion is structurally and chemically very distinct, and the sources note it's present in at least 1/3 of acute coronary syndrome cases, so it's very common. Instead of a rupture over a large fat core, this is more like the inner lining of the vessel, the endothelial cells just sloughing away or eroding.
And if there's no big lipid core, what exactly is the structure of that plaque made of?
The eroded plaque is rich in structural components like proteoglycan and glycosaminoglycan, and crucially, it has very little or no soft lipid core. The inflammatory signature is also totally different. Instead of macrophage and T cells, we see neutrophils and these structures called NETs, neutrophil extracellular traps, along with a lot of smooth muscle cells that are trying to heal the damage.
And what about the clot that forms over this eroded site? Is it different?
Because the mechanism is different, the clot is different. It tends to be a white platelet-rich thrombus. And this distinction really matters because a fibrin-rich clot and a platelet-rich clot might respond a little differently to specific anti-clotting medications. So it requires careful selection of drugs in that acute phase.
And the third mechanism.
The third mechanism, just for completeness, is similar to the first. It's a plaque fissure, but it happens without that heavy inflammatory component.
So when a physician is looking at an angiogram and they see one of these ticking time bombs, a vulnerable plaque, what visual cues are they looking for?
They're looking for signs of severe instability. Things like eccentric stenosis, which means the blockage isn't symmetrical. They're looking for scalloped or overhanging edges, and a narrow neck where the plaque connects to the vessel wall.
And it's almost never just one of these, right?
That's a critical point we really need to emphasize. NSTE-ACS is rarely a one-off event. Patients frequently have multiple such vulnerable plaques scattered throughout their entire coronary tree. So that means they're at risk for future events even if the current crisis is resolved.
We've covered three mechanisms that involve clots. But the source material also mentions a fourth process that can cause NSTE-ACS without thrombosis.
That's right, the non-thrombotic causes. These usually result from just a massive supply and demand mismatch.
How does that happen?
Well, it could be due to a severe spasm of the large epicardial arteries or even the tiny microvessels deep in the muscle, and that causes temporary but really profound oxygen deprivation. Or it could be a massive spike in myocardial oxygen demand, maybe due to a severe infection or a high blood pressure crisis happening in a vessel that already has a fixed, non-critical obstruction.
So that mild blockage suddenly becomes insufficient because the demand is just too extreme.
Exactly. The pipe wasn't totally blocked, but the demand just overwhelmed its capacity.
The anatomical findings during an angiogram are always so revealing. We often assume a heart attack means a single massive blockage. But what did the sources reveal about the distribution of disease in these NSTE-ACS patients?
Well, when NSTE-ACS patients are studied invasively, the findings are actually quite diverse. About 35% have severe three-vessel disease.
So disease in all three major arteries.
Correct. About 25% have two-vessel disease and 20% have single-vessel disease. Critically, less than 10% have stenosis of the left main artery, which is usually catastrophic. So multi-vessel disease is really the norm here.
But here is where it gets really interesting and maybe counterintuitive to what most people think. About 10% of NSTE-ACS patients have no critical epicardial stenosis at all.
That figure is surprising, isn't it? You put the catheter in, you look around, and the major vessels, the main pipes, they look relatively clear.
What does that tell you?
It strongly suggests that the acute event was caused by an obstruction in the coronary microcirculation, the tiny deep vessels we can't easily see, or maybe a severe spasm that resolved before the angiogram was even performed. This subset proves that the problem isn't always a main pipeline blockage. Sometimes it's an issue with the capillaries and arterioles that are feeding the muscle itself.
Okay, so once a patient is showing symptoms, which can range from that classic chest pain to some really strange discomfort, the challenge is rapid, accurate diagnosis. Let's start with the clinical presentation. What defines the chest discomfort of NSTE-ACS and differentiates it from, standard stable angina?
The symptoms of NSTE-ACS are characterized by a sudden change in pattern, which really indicates instability. There are 3 hallmark features. First, the discomfort occurs at rest or with minimal exertion, and it lasts for a substantial period of time, more than 10 minutes.
So it's not just a fleeting pain.
No. Second, it's of relatively recent onset, typically within the prior 2 weeks. And third, and this is key, it has a crescendo pattern. It is distinctly more severe, prolonged, or frequent than any previous chest pain episodes the patient might have had.
But as you pointed out, we can't just rely on the elephant on the chest presentation. What are those anginal equivalents, and who is most likely to present atypically?
We see these atypical presentations most often in women, the elderly, and patients with diabetes mellitus, whose pain perception is often altered.
What would they feel instead?
Their symptoms might be profound dyspnea or shortness of breath. It could be discomfort centralized in the upper abdomen, epigastric discomfort, nausea, or simply profound unexplained weakness. A good clinician has to always keep these equivalents in mind because dismissing them as non-cardiac can lead to catastrophic diagnostic delay.
When we move to the physical examination, what are the red flags that tell the medical team this is a large, severe ischemic event that's happening right now?
Signs of a large area of ischemia put immediate pressure on the heart, and that leads to some dramatic signs. You'll see diaphoresis intense, sweating pale, and cool skin, and often tachycardia, a very rapid heart rate.
And signs of heart failure.
Yes, indications of acute heart failure include a new 3rd or 4th heart sound, or basilar rales in the lungs, which suggests fluid is backing up. In the worst cases, we look for signs of low blood pressure and cardiogenic shock.
The physical exam also plays that crucial role of just eliminating mimics, right?
It's the most critical first step. Before we jump in and treat for a clot, we have to rule out other life-threatening conditions that mimic chest pain but require totally different and often contradictory treatment.
Like what?
Things like a pulmonary embolism, aortic dissection, or cardiac tamponade. I mean, if you treat a patient with an aortic dissection with antithrombotic drugs, you've essentially just worsened the catastrophe. You've made it lethal.
So we've established the symptoms in the physical exam. Now to the ECG. Since the patient doesn't have that massive ST elevation, what are the telltale electrical signs of NSTE-ACS?
Well, the most common specific finding is new ST segment depression, which shows up in about 1/3 of NSTE-ACS patients. And this depression can be dynamic, it can change over minutes, or can be persistent.
What about T-waves?
T-wave changes are also a huge clue, but they're only considered a highly specific sign of severe ischemia if they are new and deep T-wave inversions, specifically exceeding 4.3 millivolts in depth. These dynamic shifts on the ECG are basically screaming, the muscle is starving for oxygen right now.
And finally, the lab work that actually defines the diagnosis. Troponin. Why is cardiac troponin the gold standard marker for myocardial necrosis?
Cardiac troponin, either CTNI or CTNT, is the preferred marker because it's just so highly sensitive and specific. It's an internal structural protein of the heart muscle. So once cell death occurs, it leaks out into the bloodstream.
It's not just about it being present, right? It's the pattern.
Exactly. The diagnosis of NSTEMA demands demonstrating a dynamic temporal rise and fall of this concentration. It typically peaks between 12 and 24 hours after symptoms start. And what's absolutely critical for prognosis is that the degree of troponin elevation is directly related to the patient's long-term mortality risk. A massive spike means massive damage.
And with the advent of high-sensitivity troponin, the HSTN, the diagnosis has just sped up dramatically. Can you explain that rapid rule-out algorithm?
The speed is incredible. Modern guidelines now recommend a 1-hour rapid rule-out MI algorithm. So if a patient presents with chest pain and their HSTN level is below the abnormal threshold at the initial 0-hour measurement and it stays non-elevated 1 hour later, they can often be safely rolled out for an acute MI.
And that changes everything for ER flow.
It does. This rapid protocol allows for faster, safer discharge of low-risk patients, freeing up resources and reducing hospital stays.
That speed is great, but it brings us to one of the biggest clinical dilemmas in modern cardiology, distinguishing a true myocardial infarction from simple myocardial injury. If these tests are so sensitive, how do we know the troponin we're seeing isn't just a benign blip?
This is where the clinician really has to play detective. Myocardial injury is defined as any troponin elevation above the 99th percentile of the normal reference limit. But critically, it happens without the clinical history or ECG changes that suggest acute myocardial ischemia.
So it's about the context.
It's all about context. If you see the rise and fall and you have the classic symptoms, it's an MI. If you just see the elevation, it's injury, and you have to hunt for the non-coronary cause.
And that list of non-coronary causes for elevated troponin is surprisingly long and broad.
It is truly extensive. We divide them into cardiac and systemic conditions. Cardiac causes can be things like acute heart failure, myocarditis inflammation of the heart, and even the emotional stress-induced Takotsubo syndrome.
And systemic, things outside the heart.
On the systemic side, we see elevation in severe sepsis, chronic kidney disease, acute neurologic events like a stroke or a subarachnoid hemorrhage, and massive pulmonary embolism. Even really strenuous exercise can cause a transient elevation.
So in summary, troponin elevation is a red flag, but it's not always a smoking gun.
Exactly. It forces the doctor to play detective and eliminate every possible non-coronary suspect before confirming that MI diagnosis.
Okay, so once the diagnosis is confirmed and the risk is assessed, the next step is quantification using risk scores. This determines the timing of life-saving intervention. Let's look at the TIMI risk score. What are the 7 markers that contribute 1 point each, and how stark are the outcomes?
The TIMI score thrombolysis and myocardial infarction, it gives us a really rapid prognostic estimate. The 7 risk markers are age 65 or older,
Okay.
known coronary artery disease with 50% or more stenosis, ST deviation greater than 0.5 millimeters, elevated cardiac markers, 2 or more anginal episodes in the prior 24 hours, a prior history of angina, and having 3 or more general CAD risk factors like smoking, diabetes, hypertension.
The power of just summing up those 7 points is incredible. What do those scores translate to in terms of real-world risk?
They're powerful predictors of adverse events, so death, new MI, or urgent revascularization all within 14 days. If a patient scores a 0 or a 1, their risk is around 5%. If they hit a middle score, say a 3, it's about 13%.
But at the high end?
At the high end, if a patient accumulates 6 or 7 points, their risk just skyrockets to a massive 41% adverse event rate. That score immediately tells you that this patient cannot wait. The risk of a fatal outcome is just too high.
The sources also mentioned the heart pathway, which seems to simplify this initial triage logic, especially in a busy emergency department.
The heart pathway standardizes the initial evaluation of acute chest pain. After the initial ECG rules out a STEMI, the focus shifts to the heart score. It assesses history, ECG, age, risk factors, and troponin.
Heart.
Right, and this creates a low, intermediate, high-risk spectrum. If the score is low, 0 to 3, and the serial troponins are normal, the patient is often safe for early discharge. If the score is 4 or higher, or if any troponin is elevated, that patient needs admission, a cardiology consult, and planning for stress testing or angiography. It just formalizes a rapid, evidence-based process that's designed to reduce missed diagnoses without causing information overload.
We've quantified the risk. Now we have to act on it. So once a patient has ruled in for NSTE-ACS, they are admitted for continuous monitoring. And the treatment strategy relies on 2 big cornerstones: anti-ischemic therapy to reduce the damage, and antithrombotic therapy to stop the clot. Let's start with reducing that oxygen demand.
Right. Anti-ischemic therapy is all about stabilizing the patient immediately. Beyond just bed rest, the use of inhaled oxygen is actually restricted now. It's only administered if the patient is hypoxemic, meaning their O2 saturation is below 90%, or if they're showing signs of acute heart failure. The routine, widespread use of oxygen for everyone has been phased out unless it's clearly needed.
The first drug for relieving ongoing chest pain is nitrates. How quickly were they used, and what's the typical regimen?
Nitrates, usually nitroglycerin, they start sublingually to rapidly relieve angina. If that fails after, say, 3 doses, we quickly escalate to intravenous nitroglycerin.
And the IV dose?
The IV regimen starts low, often 5 to 10 micrograms per minute, and it's titrated up carefully, potentially all the way up to 200 micrograms per minute, until the patient is either pain-free or until their blood pressure drops and prevents further increase.
You mentioned nitrates reducing blood pressure. What are the absolute contraindications that have to be screened for before giving this drug?
The list is short, but it's absolutely vital. Obviously, you can't give nitrates if the patient is already hypotensive or in shock. They're also contraindicated with severe aortic stenosis. And this is the point where the technical meets the personal.
Right.
The clinician has to ask about very recent use of phosphodiesterase type 5 inhibitors erectile dysfunction drugs like sildenafil or vardenafil within the last 24 hours, or tadalafil within 48 hours.
Because the combination is dangerous.
The combination of nitrates in these drugs can cause catastrophic refractory drops in blood pressure that are truly life-threatening. I imagine that's a crucial but perhaps a little awkward question clinicians have to ask in the ER.
Beta blockers are the other major tool to reduce the heart's workload. When are they started, and when must they be avoided?
Beta blockers are a mainstay for reducing myocardial oxygen needs. They lower heart rate and blood pressure. They should be initiated early, often orally, and continued if the patient was already on them.
But there are times you can't use them.
Absolutely. We have to strictly avoid them if the patient presents with severe heart failure, shock, very low cardiac output, or if their heart rate is already too slow, say below 50 beats per minute, or if they have a high-degree AV block. The treatment goal with oral beta blockade is to bring that resting heart rate down to a nice, cool, slow 50 to 60 beats per minute.
And if the patient is still symptomatic despite maximal doses of nitrates and beta blockers, what's the next anti-ischemic step?
Then we turn to calcium channel blockers, or CCBs. Specifically the non-dihydropyridines like diltiazem or verapamil, which also slow the heart rate. These are used for persistent symptoms, or if the patient has a contraindication to beta blockers, or if we suspect the underlying cause is vasospastic angina.
And you have to be careful which one you choose.
Yes, it's very important to avoid short-acting nifedipine because it has the potential to rapidly lower blood pressure and increase sympathetic stress, which is the last thing you want.
And morphine. Is it still a standard for chest pain?
Morphine is now reserved for continued severe angina that is resistant to the maximal anti-ischemic medical therapy we just discussed.
Why do a change?
While it's highly effective for pain relief, there is a recognized pharmacologic interaction. Co-administration may actually delay absorption and potentially blunt the antiplatelet effect of PDY12 inhibitors, so its use is carefully weighed against the patient's need for pain relief.
Now let's pivot to long-term management, which starts early. The intensive lipid-lowering strategy. And we're talking extremely aggressive goals here.
We are. Early and intensive statin therapy is just non-negotiable. This means high-dose drugs like atorvastatin 80 milligrams daily or rosuvastatin 40 milligrams daily initiated immediately. This approach helps stabilize the vulnerable plaques, and that reduces both early and late recurrent events. The long-term LDL cholesterol goal is aggressive, set at less than 55 milligrams per deciliter.
That's a very challenging target to hit with statins alone for many patients. What are the adjunctive therapies?
Well, if the patient isn't hitting that sub-55 target, we add non-statin therapies, primarily ezetimibe 10 milligrams daily. If the patient remains resistant or is at very high risk, PCSK9 inhibitors or bempedoic acid are added early after the ACS event to aggressively drive that LDL-C down and halt the progression of atherosclerosis.
Okay, let's move to the second cornerstone, antithrombotic therapy. This is where we stop the clot from growing or reforming. This starts with dual antiplatelet therapy, or DAPT.
DAPT is essential. We start with the antiplatelet agent, aspirin. The initial loading dose is typically 150 to 325 milligrams. However, for maintenance, the dose is dropped to a low daily amount, usually 75 to 100 milligrams.
And why the lower maintenance dose?
The rationale is very clear. Studies show that this lower dose maintains full antiplatelet efficacy while significantly reducing the risk of major bleeding complications compared to higher doses.
Then we add the P2I12 receptor blocker. Clopidogrel used to be the default, but now we have more potent options.
Clopidogrel is still a player. It's an inactive prodrug that requires activation by the liver. When it's used with aspirin, DAPT reduces major adverse cardiovascular events by about 20% compared to aspirin alone.
But there's a problem with it.
A significant problem. We have to contend with the issue that up to 1/3 of patients have an inadequate response due to a genetic variant in the CYP2C19 liver enzyme, which impairs the drug's activation.
And that variable response pushes clinicians toward the more potent agents, prasugrel and ticagrelor. How is the decision made between them?
The decision between the potent P2Y12 inhibitors is really determined by the invasiveness of the plan and the patient's history. Both are superior to clopidogrel in preventing recurrent ischemic events, but they both carry a higher bleeding risk.
Let's start with prasugrel.
Prasugrel is an irreversible inhibitor, and it offers very robust platelet inhibition, but it has strict boundaries. It's used only when percutaneous coronary intervention stenting is planned and the coronary anatomy is known. And crucially, it is absolutely contraindicated if the patient has a prior history of stroke or TIA.
And ticagrelor is the more flexible option.
Yes. Ticagrelor is a potent but reversible inhibitor. Its benefit is seen across the full spectrum of NSTE-ACS patients, whether they're managed conservatively with medication alone or managed invasively. And that flexibility makes it extremely valuable, especially when the final decision on intervention timing or the type of intervention hasn't been made yet.
Beyond antiplatelet agents, we need parenteral anticoagulants to block the clotting cascade itself. What are the 4 key choices here?
We add 1 of 4 options to the antiplatelet regimen. We have unfractionated heparin, UFH, the classic standard. Then there's low molecular weight heparin, LMWH, which is typically enoxaparin. It's superior to UFH in reducing recurrent cardiac events, particularly in conservatively managed patients, though it comes with a modest increase in bleeding.
And the other 2?
Third is bivalirudin, which is a direct thrombin inhibitor that's often used specifically around the time of the PCI procedure. And fourth, and it's becoming increasingly popular, is fondaparinux, a synthetic factor ZA inhibitor.
Why is that one gaining popularity?
Because it has equivalent efficacy to enoxaparin, but importantly, has a significantly lower risk of major bleeding. The only caveat is that fondaparinux requires a bolus of UFH during the PCI procedure to prevent clotting on the equipment itself.
With so many strong anti-clotting drugs on board, the bleeding risk must be massive. How are clinicians systematically mitigating this danger?
Bleeding mitigation is a top priority because a major bleeding event after an ACS is strongly linked to poorer outcomes. There are 2 main strategies. First, procedural choice. If an invasive approach is used, utilizing radial arterial access, so using the wrist artery rather than the femoral artery in the groin, is strongly recommended. It dramatically reduces access site bleeding and subsequent major hemorrhage.
And the second strategy?
Dosing meticulousness. All of these agents must be carefully adjusted based on age, body weight, and renal function, especially in patients with chronic kidney disease, to prevent drug accumulation and overdose.
Finally, let's touch on a complex scenario. Patients who need long-term oral anticoagulation, maybe for atrial fibrillation, and now they also require DAT. This is a triple threat of bleeding risk.
It's the highest balancing act. The strategy here is generally to shorten the duration of DAT, especially stopping aspirin early. For these patients, the guideline is typically to continue the P2Y12 inhibitor, like clopidogrel or ticagrelor, plus the oral anticoagulant, a DOAC or VKA, for up to 1 year.
So you stop the aspirin.
Aspirin is stopped as early as hospital discharge or within the first month post-PCI. After that year, the patient transitions to anticoagulant monotherapy, stopping all antiplatelet drugs entirely to minimize that long-term bleeding risk.
This brings us to the strategic heart of NSTE-ACS management: the timing of intervention. Unlike STEMI, where the timing is always now, NSTE-ACS demands a calculated, risk-dependent approach to angiography, stenting, or bypass surgery.
The timing is structured into 3 discrete risk-based categories. This decision process forces the medical team to synthesize all the data, the clinical status, the ECG, the troponin dynamics, and the risk scores like TIMI and GRACE into a single time-sensitive action plan.
Let's start with the most urgent, the immediate invasive strategy. Who must be rushed to the catheter lab in under 2 hours?
This 2-hour window is reserved for patients exhibiting very high-risk features, which indicates active, life-threatening instability. You only need one of these criteria.
Okay, what are they?
Cardiogenic shock or unstable hemodynamics, acute heart failure that's clearly caused by ongoing ischemia, cardiac arrest after presentation, life-threatening arrhythmias like sustained VTach or VFib, mechanical complications of the MI, angina that is refractory to maximal medical treatment, or recurrent dynamic ischemic ECG changes. These patients are actively collapsing, and intervention simply cannot wait.
If the patient is stable enough not to be collapsing, but they're clearly high risk, they fall into the early invasive strategy. What is the time target here, and what criteria classify them as high risk?
The time target for these stable but high-risk patients is intervention within 24 hours. The high-risk criteria include a confirmed NSTEMI symptoms plus elevated troponin, a high GRACE risk score, specifically greater than a 140, a history of transient ST elevation that has since resolved, or dynamic ST or T wave changes. Studies consistently show that this early invasive approach reduces the risk of death or a new MI compared to a prolonged delay in this patient group.
And for the low-risk NSTE-ACS patient, the one who is stable and doesn't meet any of those criteria,
They proceed down the selective invasive strategy, which starts with conservative management. They are stabilized solely with anti-ischemic and antithrombotic therapies. They're observed closely, and the coronary arteriography is only performed later if their symptoms recur, if their biomarkers turn positive late, if their clinical assessment is unfavorable, or if non-invasive stress testing indicates severe underlying coronary artery disease.
So the default is medication and observation, followed by guided revascularization if it becomes necessary.
Exactly.
Now, once a patient is undergoing angiography and they have multivessel disease, which, as we established, is common in NSTE-ACS, how are the non-culprit lesions, the other blockages, handled alongside the primary acute blockage?
This management is determined by the patient's ongoing stability. For patients who are considered non-high risk and are stable, the preferred approach is often single-stage PCI. The goal is complete revascularization by fixing all significant blockages during that initial procedure. This reduces the need for multiple procedures and subsequent risk exposure.
But if they are very high risk post-procedure, the approach changes.
Exactly. For high-risk patients, those with ongoing shock, acute kidney injury, or complex, unfavorable coronary anatomy, we defer the non-culprit lesions. They proceed with staged revascularization. This means they stabilize the acute culprit lesion, but definitive treatment of the other complex blockages is delayed until the patient is stable, and a full discussion can be held with the heart team, often to plan complex interventions or a coronary artery bypass grafting or CAD surgery.
We've centered this whole discussion on plaque instability and resulting clots. But there is a fascinating distinct syndrome that defies this rule, first described back in 1959 by Prinzmetal, Vasospastic Angina, or VA. It presents like a heart attack but has a completely different mechanism.
VA is a pure physiological event. It's caused by the focal, intense clamping or spasm of an epicardial coronary artery. And the spasm is so intense that it causes transient transmural ischemia. The lack of blood goes all the way through the muscle wall.
And that profound temporary ischemia leads to a key distinguishing feature on the ECG, right?
Yes. While NSTE-ACS often shows ST segment depression, vasospastic angina typically presents with transient ST segment elevation, mimicking a STEMI. But crucially, there is no underlying permanent physical occlusion by a clot, just the temporary clamping of the vessel.
What drives this hypercontractility in the arteries?
The smooth muscle in the coronary arteries just becomes hyperactive. This can be provoked by various triggers, including adrenergic vasoconstrictors, leukotrienes, or serotonin. It's also worth noting that VA prevalence is highly regional. It's much more common in Asian populations, particularly in Japan, than it is in North America or Western Europe, which suggests genetic or environmental factors are at play.
What does a typical VA patient profile look like compared to the classic NSTE-ACS patient?
They're often younger and tend to have far fewer traditional coronary risk factors than a typical NSTE-ACS patient, except for one striking association. They are frequently heavy smokers. They may also have a generalized systemic vascular hypersensitivity, manifesting as chronic migraines or Raynaud's phenomenon, suggesting that their blood vessels everywhere are prone to spasm.
Since the spasm can be transient, how is the diagnosis definitively confirmed if the patient is pain-free when they arrive at the hospital?
The diagnosis starts with high clinical suspicion based on the pattern of rest pain and that transient ST segment elevation. But the definitive confirmation is often achieved during angiography using provocative testing. Under controlled conditions, clinicians can administer substances like hyperventilation or intracoronary acetylcholine to intentionally trigger the spasm.
So you make it happen in a safe setting.
Exactly. A positive test confirms the vasomotor abnormality and validates the specific treatment path.
Given that the problem is a mechanical spasm, not a clot, what is the mainstay of treatment for VA?
The treatment has to focus on relaxing that hypercontractile smooth muscle. So calcium channel blockers, CCBs, are the main therapeutic agents, and they are highly effective. Nitroglycerin also provides excellent acute relief of spasm and angina. However, the use of long-term nitrates is limited by the development of tolerance over time.
And what about aspirin? Is the cornerstone antiplatelet therapy used here?
This is a crucial caveat. Aspirin, which is life-saving in NSTE-ACS, may actually increase the severity of ischemic episodes in pure vasospastic angina.
Really? Why?
It's thought to be because aspirin can alter the balance of substances that control coronary tone. Therefore, aspirin should only be used in VA patients if they also have significant underlying fixed atherosclerotic blockages. Interestingly, statin therapy has been shown to reduce major adverse events even in pure VA, likely by improving endothelial function, even without a high cholesterol focus.
What's the long-term outlook for a VA patient?
The overall prognosis is quite good, with excellent 5-year survival rates. However, up to 20% of patients may still experience a myocardial infarction. The highest risk group are those who develop serious ischemia-associated arrhythmias like ventricular fibrillation during a spontaneous episode of spasm. These patients are at risk for sudden cardiac death and may require an implantable cardioverter defibrillator, an ICB.
Whether the patient had an NSTEMI or unstable angina, the acute crisis eventually transitions to the long game. Secondary prevention. The sources describe the time of hospital discharge as a teachable moment.
That moment is golden. The patient has just faced their mortality, and there is peak motivation to change their life. This is where the medical team needs to place intense focus on risk factor modification. Smoking cessation is non-negotiable, followed by diet modification, weight management, daily exercise, and rigorous control of blood pressure and hyperglycemia.
And those aggressive lipid goals, they continue post-discharge.
They absolutely must. The long-term LDL-C goal remains less than 55 milligrams per deciliter. This usually requires a combination therapy. High-intensity statins, often combined early with ezetimibe, and, if needed, the aggressive addition of agents like PCSK9 inhibitors or bempedoic acid to prevent future events by stabilizing the underlying plaque disease.
Beyond lipid management, what are the other crucial drug classes that are continued long-term?
Beta blockers are generally continued, as are ACE inhibitors or angiotensin receptor blockers, ARBs, especially for patients with reduced heart function or hypertension. Furthermore, we're seeing the emergence of specialized agents for type 2 diabetes, specifically SGLT2 inhibitors, or GLP-1 receptor agonists, which are recommended because of their proven benefits for cardiovascular risk, beyond just blood sugar control.
Let's circle back to long-term DPT. The standard is 12 months, but that duration is highly customized based on the balance between preventing ischemic events and causing bleeding.
Correct. The standard DAT2 regimen is low-dose aspirin, so 75 to 100 milligrams daily, plus a potent P2Y12 inhibitor, generally ticagrelor or prasugrel, for a total of 12 months. After that, they transition to single antiplatelet monotherapy to reduce long-term bleeding risk.
What if a patient has a very high risk of bleeding?
For patients with high bleeding risk or a low risk of future ischemic events, the DPT duration is shortened significantly, sometimes to as little as 3 to 6 months. The guideline then suggests stopping aspirin and continuing P2Y12 inhibitor monotherapy alone. There's also the option of de-escalation, switching from a potent agent like ticagrelor to the less potent clopidogrel, but this is typically done after 3 months and never within the first 30 days after the event, due to the heightened ischemic risk during that initial vulnerable period.
And conversely, if a patient is very high ischemic risk, say they have multivessel disease or a recent recurrent MI but low bleeding risk, can DPT be extended?
Yes, DPT can be extended up to 3 years in those specific high ischemic risk-low bleeding risk patients after careful consideration. If ticagrelor is used during this extended period, the maintenance dose should be reduced after the first year from 90 milligrams twice daily to 60 milligrams twice daily.
And just to close the loop, if the patient needs long-term anticoagulation,
all antiplatelet therapy must cease after 1 year, and they continue on oral anticoagulant monotherapy only.
it sounds like a highly structured, complex, yet evidence-based system. However, the data reveals some significant disparities in who actually receives this level of care.
It's a sobering reality. Registry data consistently shows that certain high-risk populations, including women, racial minorities, the elderly, and patients with significant comorbidities like diabetes or chronic kidney disease, are less likely to receive the full spectrum of evidence-based pharmacologic and interventional therapies.
And the outcome of that is predictable.
It is poorer long-term results for these vulnerable groups, underscoring systemic issues in care delivery.